function. Definition of a behavioral health crisis. A behavioral health crisis refers to any situation in which an individual's behavior puts them at risk of harming themselves or others, or when they are unable to function effectively due to mental illness, substance use, or developmental disabilities. Overview of the importance of crisis planning in behavioral health care. Crisis planning prepares individuals and providers to respond quickly and effectively to emergencies, reducing trauma and promoting recovery. Role of crisis planning in prevention, intervention, and post-crisis stabilization. Effective crisis planning addresses all phases of a crisis, anticipating potential triggers, ensuring immediate and appropriate response, and supporting the individual after the crisis. North Carolina Department of Health and Human Services, NCDHHS, approach to crisis services. NCDHHS coordinates a system of mobile response teams, community-based crisis centers, and suicide prevention strategies to ensure 24/7 support statewide. Section 1. Foundations of Crisis Planning. Crisis planning as a proactive tool to reduce hospitalizations and emergency room visits. Developing a crisis plan in advance helps avoid unnecessary use of emergency departments by managing crises in community settings. Integration of crisis planning into person-centered planning and treatment. Crisis plans are personalized documents developed with the individual, integrated into broader treatment plans, and reflect personal values and needs. Elements of a crisis plan. A strong crisis plan includes identification of personal triggers, effective de-escalation strategies, emergency contact details, preferred medications and treatments, and locations where the individual feels safe receiving services. Section 2. Mobile Crisis Management Services. Definition per NC. DHHS. Mobile crisis management services are intensive, on-demand interventions delivered by trained professionals to address acute behavioral health crises 24/7 in community settings. Service objectives. Provide immediate stabilization and support in natural environments, home, school, community. Ensures care is delivered where the crisis occurs to avoid escalation. Divert individuals from emergency departments and law enforcement involvement. Prevents unnecessary institutionalization or legal consequences. Composition of mobile crisis teams. Typically includes licensed clinicians, qualified professionals, and peer support specialists who bring lived experience and build trust. Target population. People of all ages facing acute mental health symptoms, substance use crises, or behavioral challenges related to developmental disabilities. Delivery model. Teams must respond within 2 hours of referral, conduct comprehensive assessments, de-escalate crises, and provide short-term follow-up or connect the individual to ongoing care. Integration with LME MCOs, local management entities. Managed care organizations fund, authorize, and coordinate these services across counties. Reimbursement and eligibility criteria. Funded through Medicaid and state dollars, eligibility typically includes any person in crisis regardless of insurance status. Section 3. Community Crisis Centers. Definition per NC DHHS. These are walk-in facilities offering immediate care and short-term stabilization for behavioral health emergencies. Function as alternatives to emergency departments. Offer a less chaotic, more supportive environment tailored to behavioral health needs. Services provided. 24-hour access to assessment and stabilization services. Licensed professionals are available around the clock to evaluate and manage symptoms. Short-term observation, medication management, and referral for further treatment. Offers brief stays for monitoring and initiates care coordination. Staffing requirements. Multidisciplinary teams with psychiatrists, nurses, licensed therapists, and certified peer support specialists. Integration with other systems. Work closely with mobile crisis teams, law enforcement, hospitals, and outpatient providers to ensure smooth transitions. Benefits. Reduce emergency room visits and inpatient hospitalizations, increase client satisfaction, and support recovery in community settings. Section 4. Suicide Prevention Strategies and Services. NCDHHS priorities for suicide prevention, early identification of risk through screening tools, use of evidence-based tools like the Columbia Suicide Severity Rating Scale, CSSRS, to identify individuals at risk, statewide training and implementation of best practices, adoption of the Zero Suicide Framework to ensure systemic, organization-wide focus on prevention. Crisis intervention services include 988 Suicide and Crisis Lifeline implementation, statewide access to trained crisis counselors via a simple national number. Crisis chat text support. Digital platforms allow individuals, especially youth, to seek help confidentially. Crisis lines managed by LME MCOs and behavioral health providers. Localized support and triage based on individual needs. Provider responsibilities, conduct risk assessments, and safety planning. All mental health providers should screen for suicide risk and develop collaborative safety plans. Incorporate suicide prevention into individualized care plans. Embed preventative strategies and coping skills in every treatment plan. Community education. Evidence-based programs like QPR and mental health first aid equip the public and professionals to identify and assist people in crisis. Integration of postvention support provides bereavement support and psychological assistance after a suicide to prevent further trauma or contagion. Section 5. System coordination and continuum of care. Coordination across crisis services, outpatient care, primary care, and social services. Integrated systems ensure individuals do not fall through the cracks between providers. Importance of shared crisis plans. Ensures all providers understand the individual's preferences and past experiences to respond effectively. Use of electronic health records and health information exchange, HIE, facilitates real-time sharing of information and supports coordinated care. Section 6, Challenges and Opportunities. Workforce shortages and rural access to crisis services. A shortage of behavioral health professionals, especially in rural NC, limits access to timely crisis care. Stigma reduction and cultural competency in crisis planning. Education and culturally informed services improve trust and effectiveness in diverse communities. Expansion of peer support in crisis response. Utilizing trained peer support specialists improves engagement and recovery outcomes. Conclusion. Crisis planning is essential for safety, recovery, and quality of care in behavioral health. When done effectively, it saves lives and preserves dignity. NCDHHS provides structured service definitions and support systems for effective crisis intervention. These definitions help guide agencies and providers statewide. Ongoing improvement efforts. These include enhancing training, improving service delivery, expanding access, and ensuring funding for sustainability. Reinforce the role of providers in integrating and honoring crisis plans. Providers must champion proactive crisis planning and uphold the individual's voice and preferences.